Okay, so I think we can start. Dear audience, welcome again. I'm Mariangela Pellegrini. I work for the ERN-EuroBloodNet, and I'm really honored to welcome all of you on behalf of the ERN and on the European Haemophilia Consortium, because indeed this program that is focusing on Willebrand disease has been planned and organized among those two institutions, so the ERN and the European Haemophilia Consortium. And here today, indeed, this consortium is represented by a patient representative that is also ePAG of the ERN, Baiba Ziemele. And this program has been really a conjoint effort because it has been co-organized by these two organisms, but it has been also created in partnership with EURORDIS-Rare Diseases Europe, and it has been supported by members of the scientific committee. We counted on Professor Sophie Susen from the CHU de Lille in France, Professor Jeroen Eikenboom from the Leiden University Medical Center in the Netherlands, and Professor Flora Peyvandi from the Ospedale Maggiore Policlinico in Milan in Italy. And I want to pass the floor to my colleague Daria Camilli for introducing the organization, the patients' organization. Thank you.
Thank you, Mariangela, and thank you, the ERN-EuroBloodNet, for cooperation and for creating such a valuable project, both for clinicians, patients, and patient organizations. So my name is Daria Camilli. I'm Education and Communication Manager at the European Haemophilia Consortium, or EHC. EHC is an international non-profit organization representing 48 national patients' organizations for people with rare bleeding disorders from 27 member states of the European Union and most member states of the Council of Europe. We represent approximately 90,000 people diagnosed with a rare bleeding condition, such as hemophilia, von Willebrand disease, and other rare bleeding disorders across Europe. Among those, von Willebrand disease is the most common bleeding disorder, affecting up to 1% of the general population. However, it is still often neglected and overshadowed by hemophilia. This program aims to distinguish von Willebrand disease from hemophilia and focuses on the particularities of this bleeding disorder. In the framework of this program, we discussed very topical areas related to von Willebrand disease among patients and healthcare professionals, and we also aim at giving visibility to the challenges of those living with this rare disease, including quality of life, access to treatment and care, medical services available in Europe, diagnosis and treatment options, and the overall patient journey through life. Today's webinar named People with VWD Bleed 2, and as you can guess from the title, we will focus on different types of bleeds, how to understand them, what is considered a serious bleed, etc. I pass the floor back to Mariangela to talk about the rules, home rules, and for some small introductions.
Thank you. Indeed, we do have home rules. So first of all, as you can see, this session is recorded. So if you don't feel at your ease with that, you can change your name in the platform, switch off your camera, or just notifying that to us, and we will take care of not displaying your name or images in our social media and channel and website. Said so, this webinar is accredited. Indeed, each session, so each webinar of this comprehensive program targeting von Willebrand disease, one session is 1 credit of the continuous medical education point of the European accreditation body, the EBA, in hematology, sorry. How you can get those credits? Well, participating to the webinar is a must. Just please, when the webinar will be finished, you will receive questionnaire, and we will ask you to answer this questionnaire. It's very quick. It will take just 1 minute, and this is a way for us for double tracking your presence, so during the webinar and during via the survey. At the end of the program, you will receive the instruction and the credits you have the rights to submit and to acquire also. So you will receive all the instructions for that. Then we can finally pass to today's session. So today's we can really count on an expert consortium for this fourth webinar of our series, because indeed we have with us, we always try to create duos. This time is a trio. So we have expert healthcare professional, and we can count on Baiba Ziemele. Also have already introduced her very quickly. And so I'm really proud to introduce to you the audience, Dr. Michel Lavin, who is a consultant hematologist in the National Coagulation Center, St. James Hospital, and researcher in the Irish Centre for Vascular Biology in Dublin. And with her, Dr. Dearbhla Doherty, that is a clinical hematology fellow on the Wellcome HRB-funded Irish Clinical Academy Training Program. And Daria, do you want to introduce our...
Of course, it's with great pleasure that I present to you the patient representative for this webinar, Baiba Ziemele, chairwoman of the Latvia Hemophilia Society, EHC Willebrand Disease Committee member, World Federation of Hemophilia, VWD and Rare Bleeding Disorders Committee member, and EuroBloodNet ePAG for bleeding disorders. With this, Baiba, the floor is yours.
Hello, everyone. Like I always say, it's always more difficult to speak about our own problems than to stand for other people who need help. So let me find my slides. I hope you can see them. So let's start with short questions. These are questions that I have seen all over my life and also from other people in our community. So why do we have this subject today about bleeds? Because we often hear that people with von Willebrand doesn't bleed. So, and only people with hemophilia can have bleeds, and especially joint bleeds. And it's always like finding any other reasons why it should be bleeding, but except von Willebrand disease. And it's also about the footballing between the doctors, because sometimes one of the doctors thinks that it's in the problem of the other doctor. And that's why we as patients are really hoping for multidisciplinary care when it comes to people with bleeding disorders. But let's see about me. I'm in my 40s. I was born when Russia had occupied Latvia many years ago, and now we live in an independent country, and we are part of European Union. So you would consider that in European Union everything is fine, but sorry, it's not the case. And we also have limited knowledge about von Willebrand, and it's not only in my family who suffers from it in many generations, but also outside of our family around us. And that's why we have these webinars to bring more information about everything that happens. So I was diagnosed when I was 7, and it happened when my sister fell down the stairs and she had a huge bruise under her eye, and it needed surgery, and it opened up and she was bleeding, and then the doctor who was treating her realized that probably there is something that we have got from our dad. But well, it was many years ago. It was like huge problems how we got diagnosed, and I'm still the only one in my family who has found out the type of my disease. And I just heard from my sister today that she was referred to genetician, and the waiting time is more than a year. She has signed up for March in 2025. Imagine how many unanswered questions she still has. And we don't have access to treatment. In Latvia, we only have one type of treatment, which is not for everyone. And I want to share here again that I'm not complaining. I'm just raising awareness of lived experience. I understand very well that other patients have different experiences, and sometimes other people are suffering more, but this is what I have lived through. So bear with me. So I was always bruised and bleeding in my childhood, and that was even before the diagnosis. I put the picture of this bloody pillow because one of the first episodes I had was when something was happening with my teeth. Probably they were changing in the kindergarten. So I remember my mom and everyone around me was always worried because it took like 2 weeks to this wound to heal. Since we lived in the country house, we always had small traumas. We were constantly cutting ourselves by just doing something, and like children, like running around. So it always happened like that. And there's a picture with a huge bruise on my leg because that was from, like, I loved biology, and I was that was a summer project, and I had to do something, and I just fell in the pond and got it like huge bruise. And this bruise was there on my leg for almost a year. So I know it sounds terrible, but it was like that. But I'm here. Everything was fine. Then when I was a teenager, I was put on hormonal contraception. It was because I had huge acne on my face, and that was like a new way how to treat it. And then only 15 years later, I realized that that it's not doing anything good for me, and that it also had side effects. So the doctor suggested I stop it, and I didn't know until I came to one of the European Haemophilia Consortium events to find out that this actually has had prevented me from terrible bleeding during the menstruations, because my sister was living through much more severe episodes than I did. And I also wanted to add that during this time, I had a biopsy, which was bleeding a lot. I couldn't like even leave doctor's office. When I was at the front door, I had to return back, and she was screaming on me because she didn't know what to do. And I was surprised because it was written with red letters on my patient card that I have a bleeding disorder, von Willebrand's, and I expected that the gynecologist would know what to do with it, but didn't. So while we are speaking about periods, I wanted to mention that I'm like other girls in our community, that I had no clue what is and what is not normal, because I still understand that not many people speak about periods openly. And that's why I share everywhere I go, from the stage, from just talking to people. I always talk about 7-2-1 rule, because I think it's the most easiest way how to understand if you're bleeding during periods is normal. So I didn't know how much I bleed before I started using menstrual cup. I don't use it anymore because it just terrifies me. And I wanted to notice here again the football between doctors, because it was always, when I was complaining to hematologist, they sent me to a gynecologist, and gynecologist said I have to go to hematologist. So I was always in between these visits and had no answer to my problems. And lately, despite the fact that all people who are getting older with von Willebrand's have their factor levels rising, mine are falling. And also the symptoms are getting more and more severe, but I still have no solution for that. But I know I have tried sometimes. I have had access to treatment with, thanks to which I know that if I can sit through 2-hour meetings like with no problems. So unlike others, I don't have many nosebleeds. I know that other people suffer with very severe nosebleeds all the time, like my dad, my brother, and my sister, but that's not the problem I have. The biggest nosebleed I can remember was like 5 hours. I was flying to London, and it was like terrible because I didn't know what to do. It just happened, and I had no previous experience. And I also had a joint bleed. And this is a story that I want to share because That's something that I hear very often from people, that we are always told that we can't have joint bleeds. But for me, this situation happened. I was calling my dad because he's the only one in our family who always have had all the whole variety of the symptoms that could be possible. And he said that he has suffered from something similar as well. And I realized that this is a joint bleed only when I saw the picture of similar hand on Facebook forum, because all the doctors that I was talking to said like, it's not possible for me. And that's pretty painful when you are going through something like that and you don't have answers, and everyone is trying to say that this is only in your mind, it couldn't be happening like that. I also had a knee bleed a few years ago, but I'm not sure if it was one. And we were trying to do ultrasound and it didn't come up like specifically that I have had a problem. So I still don't know, was it a real joint bleed or not? But I have small joint bleeds. And I heard from colleagues in our community that this is possible as well for other people. And I understand that this is not hemophilia joint, it's not the big joint, but this is very, very annoying when it hurts because it starts without reason. And then you just can't understand why it happens. And it usually takes a week to heal. And because my work is by the computer, I must write. So it's like not allowing me. And also about the spontaneous bleeds, this one is photographed because that is something that happened to me and I was shocked. I started the meeting, like here it's in the morning when I was sending pictures to my friends that hello, good morning. And when the meeting ended a few hours later, I realized there is a bleed on my eye. And by the evening, it was already all eye was blue. So I think this is the only place where I have like evidence how it happened, but still people don't believe me. They said that there was some domestic violence or it was trauma or something like that. But I know for sure that it had absolutely no reason. And yeah, I was writing also about these small problems that we always have blood somewhere. It's like for men who are shaving, they always have blood on their face, but it's also for us girls the same in other areas. So then my question for all my life was, is it a bruise or is it a hematoma? Because as a patient, I was never instructed how to find out the difference. And I think that also some of the doctors don't know how to distinguish these two things, because as I understand now from reading a lot of papers, a bruise is when it's on top of your skin. So I have these small bruises from various things, even from wearing shoes and other things like that, from insect bites, or I don't know, you can name it, but every time when I touch something, it appears a small bruise. But the biggest problem are these huge bruises that are hematomas, because they are always raised, they are always painful, they are swelling, and that it takes much longer time for them to heal. And this is, I think, my last slide. I just wanted to sum up everything because I think I have taken too much time already. But I just wanted to tell you that these spontaneous bleeds are very, I don't know the word in English, but they are very annoying because they are restricting me from spending time with my friends outdoors, because I'm always worried if I fall, what happens? If there is a car accident, what happens? If I ride a bike, I'm so clumsy, I would definitely fall and something bad would happen. And I'm not sure if I could get medical help. And I have seen my dad and my sister and other relatives having very serious bleeds. And I think that like the strategy of my sister and brother who also have von Willebrand's is that they are ignoring it and they just hope it will end. I'm different. I'm trying to find answers. You see, I'm trying to get it on a very large scale, so all people would get answers, not just me, myself. And another thing that restricts my life as a normal person is that I can't have procedures like others. It includes massages, facial treatments, dental procedures, because it's always like bruises on my face, even shaving legs or waxing. It also always has a lot of blood, and small invasive procedures, or sometimes it's even that when I need some procedure or surgery, I always have to go to hematologist. The waiting time is about half a year sometimes. So most of the time, the answer is that it's not so serious that you need a surgery. So I never understand if it's like that or not. I was also told that people like me shouldn't have children. I can't get over this, because I also saw my sister that she didn't have the medical help when she had a child, and she had very severe postpartum bleed. And I'm not sure if my country would be able to work out with that even now, 14 years later. And my coping strategies, because I was always trying to like not allow this thing take over control of my life. I always face this issue. Then I cry because I just can't. Like, I'm a girl, I always cry. Then I dress up and I smile. But this turns out that it's very bad, because they have no documented evidence of everything that I have gone through. So when I need evidence from my medical records, it's not there, because I was trying to do everything on my own and not to bother our medical system. But I also know that others bleed more, but I'm not mild. And so with that, thank you very much for allowing me sharing my experience again. I hope it will help you set the scene for all people living with von Willebrand's, what we go through. Thank you.
Thank you, Baiba.
So Michelle is very kindly going to share and move the slides on my behalf because of technical issues. So I'll be doing the first part of this presentation. I'll be discussing firstly on the next slide what symptoms patients with people with von Willebrand disease experience, which Baiba has already very nicely explained from a personal point of view, and how we try as doctors to objectively assess the bleeding symptoms of people with von Willebrand disease. So on the next slide, we try and categorize symptoms into groups. So we talk about spontaneous bleeding symptoms, female-specific bleeding, and then bleeding with challenges. So firstly, to focus on spontaneous bleeding, as Baiba has so nicely illustrated, bleeding can occur just out of the blue in people with von Willebrand disease. So some patients will have nosebleeds, also known as epistaxis. Some people will just have big bruises that come out of the blue. People can also have prolonged bleeding from wounds, as we've heard, less commonly bleeding when passing urine or from the gut, and then also joint and muscle bleeds, which are starting to become much more recognized, and Michelle will talk about later in the presentation. And next, for women in particular, there is the extra burden of what we call female-specific bleeding. So Baiba has already alluded to the 721. This is a tool to try and help women recognize when their bleeding is heavier than perhaps it should be at the time of their periods. So any period bleeding that's longer than 7 days, the need to change pads or tampons more than every 2 hours, and then passing clots that are bigger than the size of a euro coin are all signals that this bleeding might be disproportionately heavy and should be looked into. We also talk about postpartum hemorrhage, which is another female-specific challenge. So this is after delivery, which is obviously a huge burden on the body. A woman can suffer from bleeding either in the first 24 hours following delivery, and this is what we call primary postpartum hemorrhage, or else she can start to bleed after 24 hours, and that can occur up to 6 weeks and often when she has gone home from hospital. And this secondary postpartum hemorrhage is actually particularly common in women with von Willebrand disease. And then finally, we have bleeding with challenges. So this is things like surgery or other procedures. We heard about a cervical biopsy, for example, or bleeding after dental extraction, where people with von Willebrand's disease will bleed disproportionately to what we would see in other individuals. So next, we as doctors try to objectively measure how much individuals with von Willebrand's disease bleed. And over the years, there has been attempts to develop bleeding scores, also known as bleeding assessment tools. So back in 2005, there was the first attempt by an Italian group with the Vicenza score. And this essentially gives a number to every bleeding symptom that a person with von Willebrand's disease has. And you'll see as you read the literature that there's lots of different types of bleeding scores. The ones that you might most commonly come across are the condensed MCMDM1 score, which was from 2008, and the ISTH BAT score in 2010, which is the ISTH recommended bleeding assessment tool. And then more recently in 2015, the ISTH BAT was modified by some Canadian researchers to allow for people with von Willebrand's disease and other bleeding disorders to administer the tool to themselves prior to seeing a medical professional. So when we're thinking about BATs, we split bleeding into different groups, different domains, like I mentioned already. So the spontaneous bleeding domains, the challenge domains, and the sex-specific domains. And really importantly, different individuals are going to have completely different bleeding, even in the same family, as we've heard. So it's really important to assess an individual patient's bleeding history. And typically within the ISTH BAT, each of those domains, for example, nosebleeds, are given a score from 0 to 4. So 0 being the absence of any significant bleeding, and then increasing up through the presence of symptoms, the need to seek medical attention, the need for perhaps medications to manage the bleeding. And then usually the highest scores would be given to people who have required surgical intervention, for example, to manage their bleeding. So in the clinic, we typically use bleeding scores for two reasons. We firstly try to use them to identify people in the community that might have von Willebrand's disease and not even know it, and to pick them out of the general population. And the second use is called prognostic. And this is where we try and identify how severe an individual patient's bleeding phenotype is, whether it might be on the milder end of the spectrum or on the more severe end of the spectrum, and perhaps needing regular treatment to manage their bleeding symptoms and frequent clinic reviews. So we've done some work recently on trying to improve bleeding scores, and I'll just talk through three kind of recent developments in how we think about using bleeding scores in the clinic. So the first is going back to that question of how we pick out an individual who may have von Willebrand's disease and be in the community and not realize that they have von Willebrand's disease. And how do we identify abnormal bleeding, and how do we quantify abnormal bleeding? So the most important thing for this is to try and figure out what normal bleeding is. So on the next image, we can see that in order to try figure out what abnormal bleeding is, we first need to understand normal. And to do this, researchers, mainly in the US and Canada, have asked lots and lots of healthy people about their bleeding. And that allows us to see that for the majority of, for example, women on this slide, most healthy women who do not have a bleeding disorder will have bleeding scores, an ISTH BAT score that falls between 0 and 5. So we can say that any woman who has a bleeding score of 6 or above, we should probably consider as having abnormal bleeding and maybe needing to have medical investigation. So next, we can see that these normal ranges, which is what we refer to for bleeding scores, are different because we know that adult females and adult males are going to have undergone different challenges during their life. For example, women will have the challenges of menstruation and also perhaps delivery. And children, for example, will very rarely have undergone any surgery by the time that they're diagnosed. So for that reason, children have quite a low normal range of 0 to 2. Males are a little bit higher at 0 to 3, and adult females are a bit higher at 0 to 5. But we wondered whether this adult female reference range of 0 to 5, which is quite broad, we wondered whether this was relevant to an adult woman, regardless of when you saw her through her lifespan, because obviously at the age of 18, a woman is going to have undergone very different challenges to that of a woman when she's perhaps 80. So on the next slide, we can see that we reached out to Dr. Paula James from the University of Kingston in Canada. And so she has a large database of healthy female controls. And these are all healthy women who have answered bleeding score questionnaires. And this has allowed us to develop the reference ranges, which are what the normal ranges are currently based on. So on the next slide, we can see that we looked at trying to separate out bleeding scores based on women's age. So we firstly looked at the overall group and we confirmed that yes, indeed, the normal range for women is between 0 and 5. But we can see here that the bleeding scores increase as women age. So on the next image, we can see that older women are around 3 times more likely to have scores of 4 or above when compared to younger women. And this actually meant that when we see the next graphic, women in the middle, so women between 31 and 51 years of age, had a normal range of between 0 and 5. So that's our current reference range. However, next, when we looked at younger women, so women between 18 and 30, we can see that the normal range is actually narrower. It's between 0 and 4. And then finally, when we looked at older women, 52 or above, we can see that their normal range was actually a little bit broader, between 0 and 6. And then next, we looked at the factors that were driving this change in the normal range with aging. And we found that, as expected, as women aged, even healthy women without a bleeding disorder would undergo increased exposure to surgeries and dental extractions. And even if you don't have a bleeding disorder, some of those individuals are going to just spontaneously have a bleed. In addition, lots of people without a bleeding disorder also have heavy menstrual bleeding. And as those women progress through life, they're going to be offered more interventions for their heavy menstrual bleeding up to and including hysterectomy. And both of those factors combine to lead to an increase in variability in bleeding scores with aging. So on the next slide, we can see what that means. Well, if we're trying to find that one individual in the community who has von Willebrand's disease, we perhaps are setting the bar a little bit too high with a normal range of 0 to 5 for a younger woman. Because if we see her when she's 18 and she hasn't undergone any surgeries or dental extractions, she may be labeled as having a normal bleeding score, even though for her age and her challenges, that score is quite abnormal. And in contrast, an older woman who's undergone surgeries and dental extractions and perhaps had a few deliveries, a score of 6 for her might be actually perfectly normal for her age. So to us, this suggests, and further research will hopefully confirm in other cohorts, that age-adjusted reference ranges might be appropriate in the diagnostic assessment of women with bleeding disorders. Another interesting development that's been made in bleeding scores in recent years was led by Michelle Lavin, and this is identifying, particularly for gynecological bleeding, that different bleeding scores behave differently. So as I mentioned, the 2 most common bleeding scores that you'll come across in the literature are the condensed MCMDM1 score and the ISTH BAT score. And although the ISTH BAT is the ISTH recommended bleeding assessment tool, a lot of research papers will use the condensed MCMDM1 score as their preferential tool. And let's take, for example, a 19-year-old woman who's had heavy periods since they came on. She changes her pads hourly, she uses double protection, she leaks through clothing frequently, and she's never seen her doctor because her mum and her sister also have similar periods. Now, her ISTH BAT score for her heavy menstrual bleeding is a 3, and that's a 3 out of 4. So that's quite significant because she's had heavy bleeding since her period started and lasting over a year. However, on her condensed MCMDM1 score, she'll actually get a 0. And that's because in order to score on that particular bleeding score, women need to have sought medical attention. And in the image on the right, we can see that this was really nicely shown by Michelle in a Blood Advances paper a few years ago, that in women with low von Willebrand factor levels, their ISTH BAT scores will be significantly higher than their condensed MCMDM1 scores. And these are women with the exact same bleeding symptoms. It's just the way that we are assessing them. So perhaps suggesting that the ISTH BAT is a better tool in order to assess bleeding symptoms in women with von Willebrand's disease. And the final development that was also led by Michelle in association with Dr. Paula James is how we can assess ongoing bleeding in individuals with von Willebrand's disease. And this is where the idea of an interim bleeding score was published. So we can see that on the left, when we diagnose a patient, we will do an ISTH BAT score to try and assess their bleeding up to that point. But we know that going forward, that individual is going to have bleeding as they progress through life, spontaneous bleeding, but also bleeding when they undergo challenges. And it has been very difficult up until this point to try and objectively assess how we quantify that bleeding over time, both in the clinic and also in the research setting. So the interim BAT score was developed, and this is quite simply a repeat BAT at each at a variable time point, and symptoms can then be assessed over the number of years between the bleeding scores. So quite a simple concept, but a really helpful tool to be able to assess ongoing bleeding following diagnosis. And in the next graphic, we can see that this paper highlighted some important findings that mightn't have been accessible if there wasn't an objective way to monitor longitudinal bleeding, including that even, as Baiba mentioned, as von Willebrand factor levels in some patients can normalize with age, some people continue to experience bleeding symptoms even with those increased levels, suggesting there may be other modifiers causing their bleeding. And in addition, the researchers found that the interim bleeding scores were actually similar, even if a patient had a positive or a negative initial bleeding score, meaning that we shouldn't just discount patients who may have a negative bleeding score when we first assess them. So as a take-home message from this symptom and bleeding score focused part, people with von Willebrand's disease, as we've heard, can experience a wide range of bleeding symptoms, and that includes spontaneous bleeding, female-specific bleeding, and also bleeding following any challenges. And bleeding scores or bleeding assessment tools are tools that quantify bleeding, and they tell us what bleeding is normal and abnormal. And this can help us to identify people with von Willebrand's disease. It also allows us to assess the severity of a patient's bleeding symptoms and attempt to monitor bleeding over time.
Thank you, Dearbhla, and I'm going to take over the next section of this talk, which is focusing on joint and muscle bleeds in people with von Willebrand disease. And I didn't speak to Baiba, our coordinator. I didn't know what Baiba was going to present on today, but we both came to the same point that it's really underappreciated as a problem with people with von Willebrand disease. And certainly, I think an important point of that of the questionnaires that Dearbhla was talking about earlier is that they take into account patient-reported symptoms, not symptoms that have been, a bleed that's been diagnosed on an ultrasound or on a scan. It's actually what your patient is telling you in terms of their bleeding history. And I think that's critically important when it comes to people with bleeding disorders, because not everyone will present with every bleed because they've learned to self-manage at home. So when we think about, joint bleeding, and again, Baiba and I did not coordinate this, but, again and again, we hear that joint bleeds affect only people with hemophilia. So there's this ingrained belief that it's factor 8 or factor 9 deficient patients, and that it's men, because we think about men when we think about people with hemophilia, even though, of course, women can also be affected. But if you have von Willebrand disease, you have a secondary deficiency of factor 8, because von Willebrand serves to carry factor 8 around the body. So everyone with von Willebrand disease will typically have reduced factor 8 levels, and particularly those who have type 3 von Willebrand disease can often have factor 8 levels in the moderate or severe range as if they had hemophilia. But it's not just people with type 3 VWD that can experience joint bleeding. And I think it's very easy for us to overlook or discount this or underappreciate this problem. And females in particular who present with symptoms of joint or muscle bleeds can struggle to get recognized or to even have that diagnosis considered. And this is data from one of the largest type 3 von Willebrand disease studies, the Three Winters IPS study. And it just looks at the frequency of bleeding symptoms experienced by 223 patients with von Willebrand disease, type 3 von Willebrand disease. And you can see between females and males, we have 40 to 51% of type 3 VWD people experiencing hemarthrosis or joint bleeding. So really common. And in comparison to the type 1 VWD people within that study, that it was 9 times more likely to have a joint bleed in those with type 3 than type 1 von Willebrand disease. But that's not to say it didn't occur amongst patients with type 1 VWD. And in the WIN study, which is the von Willebrand study in the Netherlands, that recruited patients with von Willebrand disease who had levels less than 30 IU per deciliter, or 30%. And 23% of all the patients recruited self-reported a history of joint bleeding. Now, when you look at the data, it's about 56% female that reported joint bleeding in patients with von Willebrand disease. And you can see this is a very large cohort of patients, of over 800 patients overall. But when you look at the subtypes or the type of von Willebrand disease, only 12% of those reporting joint bleeds had type 3 VWD. And of course, this is influenced by the frequency at which type 3 VWD occurs, because it's quite rare in comparison to the other types of von Willebrand disease. But 54% of joint bleeds occurred in patients with type 1 and 34% in patients with type 2 VWD. And when they looked at the impact of having joint bleeds, there was higher rates of joint damage in those who reported bleeding versus those who did not report a history of joint bleeding. There was lower health-related quality of life and pain, health-related quality of life scores in those who reported joint bleeding and higher pain scores. And 55 patients had objective joint bleeding data. And when they looked back on that, 2/3 of them had had their first bleed as a child. So people with VWD are at risk of accumulating joint bleeds and joint damage from childhood in the same way that patients with hemophilia, we now understand that this can occur at an early age. We need to better understand this in our people with von Willebrand disease. So from this study, there was more clotting factor concentrate usage, more joint pain, lower health-related quality of life scores, and significantly more self-reported and radiologically proven joint damage in people with von Willebrand disease who self-reported joint bleeding. And in this study of European women who were surveyed about their bleeding symptoms, and this is women who have all different types of bleeding disorders, you can see that actually the rates of joint bleeding were higher reported in patients with von Willebrand disease than in carriers of hemophilia who had levels less than 40%, who will be now classified as having mild or more severe hemophilia depending on their baseline levels. So they experienced it in about 6% of women reported it, but about 12% of women with von Willebrand disease reported having a history of joint or muscle bleeds. So I don't think we can continue to discount this symptom the way it has been in the past. So joint bleeds are not restricted to those with type 3 von Willebrand disease or just to men. People with von Willebrand disease and joint bleeding have negative impacts in terms of both their health-related quality of life and their pain scores. And improved awareness is needed amongst both the patient community that this can occur and amongst the treating hospitals to actually take this seriously and to manage it appropriately. So now moving on to understanding the burden of bleeding. And we were asked to discuss the topic of iron deficiency. And I would say this is probably the most common problem I come across in my clinic among people with all different kinds of bleeding disorders. And it's inevitable that you will develop iron deficiency if you continue to have recurrent or persistent or prolonged bleeding, because your iron loss in blood will actually exceed the amount of iron that you take in your diet. So in terms of people with von Willebrand disease, those who have gastrointestinal bleeding, so things like angiodysplasia, who have frequent or heavy nosebleeds, are in particular probably the largest group is women with heavy menstrual bleeding. They will be very likely to develop iron deficiency, and if prolonged, this will ultimately progress into iron deficiency anemia. And I think it's really important that we understand that anemia is the end consequence of a long period of iron deficiency. you do not develop anemia overnight. So we should see the development of anemia as a failure to detect a long period of iron deficiency and a failure to treat our patients appropriately to prevent them from getting anemia. And if we're looking for iron deficiency, we should look for ferritin and transferrin saturations and not be waiting until somebody becomes anemic to then test their iron status, because we've missed our opportunity at that point. And it's difficult because the signs of iron deficiency are really non-specific, and many of these symptoms overlap with problems in the general population. And certainly amongst the many women that I see who have heavy periods, they may be caring for their family members, they may be working as well, and they're not surprised if they're tired or they have poor concentration or if they're irritable. You know, they don't necessarily think that this could be related to iron deficiency. So it's easy for both patients, but also for healthcare providers to trivialize iron deficiency symptoms or dismiss them. But iron deficiency can have important impacts on cognition and physical and social functioning. So in this study where they treated people with iron, you can see that their number of words recalled in terms of it was an assessment of cognitive status was lower pre-iron than it was post-iron. Another study looking at physical functioning where they treated either people with placebo or iron, you can see that there was an improvement in endurance time when they encouraged these children to run after getting iron. And in terms of those patients and people reporting constant tiredness, those who are iron deficient are seen in the paler red here. So there's a much higher rate of constant tiredness reported in both young and middle age in comparison to people who are iron replete. So these are insidious impacts on people's lives that are easy to overlook, but can have a major impact. And women with von Willebrand disease are uniquely vulnerable to this, because if you look at self-reported heavy menstrual bleeding, in comparison to those with other bleeding disorders, the rates are much higher. Heavy menstrual bleeding occurs in much more frequency in people with von Willebrand disease. And what happens if you're iron deficient and you have heavy menstrual bleeding? Well, if you become pregnant, you're going to become much more iron deficient, and you will very likely become anemic, because you absorb about 1 milligram of iron per day. But during pregnancy, your requirements for iron increase significantly. And that's due to the higher blood volume, but also the increased cell turnover and the demands of the placenta and the growing fetus. So when we think about iron in the mother, we have to think about the entire fetal-placental maternal unit, because the fetus or the growing baby is entirely reliant on the maternal iron stores. And fetal iron absorption will increase significantly in the third trimester, because as a newborn, the fetus iron can't pass into the newborn's brain through the blood-brain barrier for the first number of months of life. So they're really reliant on the iron absorption during pregnancy in order to feed their growing neural development. And if iron is reduced in the setting of iron deficiency, you'll see that immediately placental iron receptors will increase, because the priority will be to optimize the fetal iron levels. So this will put the mother at risk of iron deficiency and of anemia, which is associated with a higher risk of postpartum hemorrhage, premature delivery, and low birth weight infant. And when does the fetus become at risk of developing iron deficiency? Well, once the maternal ferritin drops below 13, then there is a risk that the fetus themselves will start to become iron deficient if this iron deficiency is not corrected. And there's concerning data emerging about the neurocognitive development of children that are born to iron deficient mothers. In this study of almost 300 children, where they divided the children into quartiles based on what their cord ferritin or their iron stores taken from their cord at birth were, those in the lowest cord ferritin quartile scored lower on every test when it came to language ability, fine and gross motor skills, attention and tractability at 5-year follow-up. So I don't think we can trivialize iron deficiency as a benign condition. You know, there's impacts that we don't fully understand, and I think we need to be looking for and treating it much more aggressively than we are at the moment. So how do we manage iron deficiency? Well, it can take 3 to 6 months, but the oral iron to replenish your stores, but you should start to see an improvement within the 1st to 6 weeks. And it's important that you should give a single tablet on an alternate day dosing schedule. And this is based on randomized controlled data that was published in the Lancet Haematology in about 5 or 6 years ago, where they took iron deficient women and randomized them to either daily or alternate day iron. And actually, the time to iron recovery was much better in the alternate day treatment program rather than women that were taking iron every day. And this is largely related to the development of if you take iron every day, you will induce a hormone called hepcidin, which will actually block iron absorption and leave you with more GI or more iron sitting in your gut and side effects. So, although people will come often looking for iron through intravenously, the first thing I'll ask them is how have they been taking iron before? And it's not uncommon to have seen people say, oh, I was told to take it 2 or 3 times a day. And, undoubtedly they can't tolerate iron that way. They will get a lot of symptoms, a lot of constipation, abdominal pain. And also they're not absorbing as much because it's just sitting in their gut. So I'll often retrial them on an alternate day dosing schedule and see if they can tolerate even 3 times or twice a week iron and watch their iron stores. If they improve, they may not need IV iron. If they fail to take iron in that way, then we'll consider intravenous iron. So iron deficiency is common. It's often attributed to other causes. The treatment is cheap, it's easy, it's widely available, and we shouldn't discount this as an important cause of morbidity amongst women and everyone with bleeding disorders. So finally, I'll finish up on how we move to the future. I really, truly believe that we as a community need to make people with von Willebrand disease more visible, louder. We should be demanding change and we should be looking for better treatment options all the time. And part of the problem is that this is a rare disorder, but it also hasn't been a visible disorder. So we need to get people with von Willebrand disease registered so that they can be counted, that their voices can be heard, and that we can show people the burden that people face on a daily basis in order to try and improve it. So what's the expected prevalence of haemophilia? It's about 1 in 10,000. And everybody who knows anything about bleeding disorders knows about haemophilia. They may not know about von Willebrand disease, despite all of our efforts. But von Willebrand factor is reduced in about 1 in 100 people, and you get von Willebrand disease in about 1 in 1,000 people. So it should be at least 10 times more common than haemophilia. And looking at this data from the annual global survey about, prevalence rates of registration rates of haemophilia across Europe, you can see that it's hitting in or around the expected prevalence of 1 in 10,000 across Europe. If we look at that for von Willebrand disease, it looks like we're doing okay in terms of more than 1 in 10,000, but we should have an expected prevalence of 1 in 1,000, so 10 per 10,000. So when you graph it that way and put the line of where we expect things to be, you can see we're not doing all that well. Ireland we're not doing too bad, but we're still at only about 3 per 10,000. And however bad it is in Europe, across the world, it's the expected and the actual registration rates are so widely divergent. In this graph, which came from the annual global survey data from the World Federation of Haemophilia, you can see we had to graph per million population to even include some of the countries on the graph settings. So some countries were seeing 1 per million, not 1 per 100 or per 1,000 people registered with von Willebrand disease. So there's huge amounts of work to be done. I'm excited that the World Federation of Haemophilia has been taking this really seriously and has included a von Willebrand disease module in the World Bleeding Disorder Registry. That was added in February 2023. So they presented the first 10 months of data from the WBDR, and that was recently published and is available on their website. And there's an app function, and national member organizations and hospitals and patients can upload data to this. But from the data in the first 10 months of having a VWD module, we have almost 1,000 patients already enrolled, with the majority female, but we would expect to be about 2/3 female to 1/3 male across most countries because of the problems that women see with heavy menstrual bleeding, leading to more females diagnosed with von Willebrand disease. From this WBDR, about 2/3 of the patients have come from lower and lower middle income countries, which is really exciting. It actually is one of the largest international registries now of people with type 3 VWD. We've over 500 patients in the first 10 months of registration, which is fantastic. But despite this and the fact that it's skewed towards the most severe types of VWD, we only have 2% of people on prophylaxis last year. Now compare this to the data from the haemophilia reporting countries, in which 29% of adults and 27% of children with severe haemophilia received prophylaxis in 2023. It shows how much further we have to go as a community. So the take-home messages from this section is that heightened visibility is going to help to drive change, but we still have diagnostic rates that lag behind the expected prevalence. And there's very low rates of prophylaxis used in the first year of the WBDR. Perhaps as we accumulate more data, we'll see better uptake and better figures regarding prophylaxis. We'll have to wait and see. So in summary, for both Dearbhla and my talk, in terms of symptom recognition, we need to listen to our patients. We need the bleeding that is experienced by people with von Willebrand disease is often trivialized or normalized. Nosebleeds and heavy menstrual bleeding are the most commonly reported symptom, but joint bleeds are not restricted to those with type 3 VWD. Bleeding assessment tools are helpful to identify patients with von Willebrand disease, assess severity, and when we talk about that, we're talking about the severity of bleeding. And that often is different from the severity of the levels. And I really don't like it when I hear somebody being referred to as having mild von Willebrand disease based on the levels, because they may not be mild at all when you ask them about their bleeding symptoms. They can be used to monitor bleeding over time, and we're conducting ongoing research to improve our use and implementation and simplification of BATs to make them more accessible to all. And in terms of monitoring and follow-up, regular screening for iron deficiency is essential. You should be trying to optimize iron stores, particularly if women are considering becoming pregnant. We need to better understand the challenges facing people with von Willebrand disease internationally and address the problems regarding the use of prophylaxis in people with von Willebrand disease. And with that, I'll hand it back to the chairs for question and answers. Thank you.
Thank you very much to the three of you for this comprehensive overview indeed on the topic. So I see we have received quite a few questions. So shall I start, Daria?
Yes, or I can, because it's my dear EHC VWD Committee co-chair.
Yes, that's why I was asking. Yes. Please go.
So it's
a
question
honor.
from EHC VWD Committee co-chair Joe Tronter. So the question would be to the whole panel: how do we challenge consultants when they tell us we as VWD patients cannot have joint bleeds? So how to address this question?
I might start on that. I think the problem is that there's so much focus on joint bleeding for haemophilia and not for VWD. And there is more of a change of this. You hear being spoken about in sessions about it, and people talking about it more. I think it's going to take a long time for that to filter down. So, I would encourage people, if they are having problems about, to say, well, actually, I can have joint bleeds. I know that I can have low factor VIII levels with my von Willebrands, but even with von Willebrand disease, I can have joint bleeds, and I really want to have this assessed. And, I think the days of doctors knowing everything and making your decisions, that should be long gone. It should always be a shared patient decision-making process. And, as a doctor, I shouldn't make decisions for you. I make them with you. And that's the relationship we have to build with our patients, and for our patients to feel empowered to frankly discuss their problems with their doctor.
Thank you so much.
Yeah, I agree. I think education of the medical community is the most important thing, but that is definitely going to take time.
But that's what we are also doing with this amazing program, actually. And I see Mariangela wanted to say the same, probably. Baiba?
I just think that we as patients have to talk as well. That's why I said that my strategy of hiding all the symptoms and everything has done wrong to me as a patient, and also probably for doctors, because they missed the opportunity to follow my case for 40 years to understand that it's actually like sometimes very difficult situations that could have been prevented.
Thank you.
Thank you. So I move to the other question. I will read the first of a series of 3. So the first, to confirm to Dearbhla, the older we get, the more we bleed. I see this because I have a von Willebrand disease type 3, and I'm 42 years old, and I see that I have more and more bleeds. I mean spontaneous one, and I don't even count the traumatic one.
So the study I was referencing was actually about healthy women, and how we quantify bleeding actually changes as a woman ages. So more that women will have undergone more challenges when they're older, which will make their bleeding score higher. And in healthy women, we wouldn't expect their bleeding to particularly change. So it's more about the scoring than the bleeding itself. But certainly there has been other research on the changing of von Willebrand disease bleeding with aging in the WIN study particularly. Now this compared older patients with younger patients, so it didn't look at individual patients over time, but they certainly saw that in some in older patients there was more joint bleeding, there was more gut bleeding, in the year prior to the joining of the study. So what we probably need is studies looking at individual patients going forward to try figure out how their bleeding changes over time. And that's hopefully what things like the interim bleeding score will help us to do in the future.
And I might just add as well, you know, when I I used to worry a lot about girls at menarche, you know, when they were starting their periods, that was a really risky time for having heavy or difficult to control bleeds. Now it's just because this person is mentioning they're 42, it's women in their 40s are probably my trickiest group, because as you approach your menopause, you can get hugely variable bleeding, and that's just normal in the general population because the hormones that control your cycle start to decouple and you can have irregular bleeding, and then because the womb lining has built up over a couple of months where you haven't had a period, suddenly you get a catastrophic period and it's a disaster. So, you know, perimenopausal is a very fraught time for women in terms of having people who have had controlled bleeding can suddenly have very poorly controlled bleeding you know, it can suddenly flip between the two over a very short period of time. And just if people have that issue when it comes to heavy menstrual bleeding around the menopause, I'd strongly consider them to, you know, urge them to consider a coil or an intrauterine device, because that's probably what we see the best resolution with bleeding when it comes to heavy periods around the menopause. So that's one thing, just because when I see women in their 40s, I start telling them before they have a problem to anticipate this problem and to think about a coil in their future, you know, so even if you're okay now, you may not be in a year or two. As you age, you can be more likely to get, as Dearbhla said, joint bleeding and gut bleeding, and that's in the general population. It isn't joint problems are more of a problem rather than bleeding, but just because you start to develop more age-related problems, you can get bleeding complications from it. So certainly for somebody with type 3 von Willebrand disease, you know, it may be a time to think about going on more prophylaxis if you have access to that, if bleeding becomes a problem. But people's bleeding can change over their lifespan, and it's something we need to be attuned to, and you need to talk to your centre about it if it's becoming a problem.
Thank you, Michelle. We have a question to Baiba. Baiba, according to your experience, what can we do to make the clinicians understand that we also bleed and that all bleeds are important? A nosebleed of 5 hours is not normal, and of 3 days even less.
I think one of the things is something like this: when doctors come together with patients and we learn from both sides, we tell our symptoms, and doctors realize that this is not only in the box, but it's actually people behind those that are suffering all these symptoms. And I also think that for them to realize that we actually bleed, like we can't make them read all the new literature about it, like all the surveys and all the studies that are published around the world. But I think if they agree to participate in the World Bleeding Disorders Registry and start compiling this data, because I just was reading what the other girls were saying, that we are not recording our symptoms because we, for many years, we had no possibility to do that. And if we can somehow convince our hospitals to join the registry, we would have a platform in which we can easily write down all the symptoms, even for us. So it's only collaboration and cooperation, and that's the way forward to improve knowledge on both sides.
And I think, Baiba, as well, people need to expect better. I think people with von Willebrand disease have got used to living with bleeding in a way that we should consider unacceptable. You know, it's not okay to have bad nosebleeds and just plug your nose at home and hope it settles after an hour. You know, we need to be going in, contacting your center and saying, I'm having a problem. And I think the more that hospitals are hearing people with von Willebrand disease saying, I'm bleeding and it's a problem, the more serious they're going to take this condition as well. It shouldn't be on the patient to educate us. We need to educate ourselves too.
Thank you. And then we have another question for you, Michelle. So women with von Willebrand disease are used to live with anemia. The question is, when is normal, and is it better to take iron tablet or IV?
So anemia is never normal. I know we can normalize it by getting used to walking around with hemoglobins of 8, 9, 10, but it's never normal and you shouldn't accept it. And if you're having heavy periods, or if you're having really bad nosebleeds, you know, if you're frequently bleeding, I mean, start iron tablets. Don't even wait to go to your doctor and get your blood test done if that's going to delay things. It's not going to harm you to go on iron tablets if you're having regular bleeding, because and alternate day iron, just so every second day taking an iron tablet. So, you know, I'd say to people 3 times a week, if you can fit that into your schedule, that would be great. But you should never accept iron deficiency, and you should never accept anemia, because it's going to affect your performance, your concentration, your tiredness, and life's too short. So expect more for yourself, and, you know, and make sure you're getting your iron checked and you're getting treated. In terms of intravenous, when you need intravenous, it's really only for people who fail oral iron. So if you can't take the iron tablets, if you can't tolerate them, I have a few people who, you know, they get sick all the time if they take them, or they're very unwell with them. Often if you try changing around brands, you'll find some brand that is suitable for you. But I encourage people to take proper iron tablets, because there's some that are in health food stores that have very little iron. You're not going to benefit from those. You need an iron supplement that's specifically for iron, not a multivitamin.
Thank you so much. A question from another co-chair of von Willebrand committee. Is it possible to have a minor joint bleed without any swelling? What's the best method to detect or diagnose such bleeds? I had one major joint bleed 12 years ago, and since then I struggle with heavy pain and immobility for a few days every few months.
Will I hop in? I realize I'm answering a lot, so I'm trying not to talk over my my co-presenters. In terms of, I think there's another question further down about how to best diagnose joint bleeding in VW. I think we don't really know, is the long and short answer. So there's all the studies about joint bleeds have largely recruited people with haemophilia. They have used some of the haemophilia scores in patients with von Willebrand disease and shown that, you know, things like the Haemophilia Joint Health Score will work for looking at long-term joint damage for people with von Willebrand disease. But when it comes to a joint bleed, it's largely a clinical diagnosis. So if somebody comes in with a hot, swollen, red joint that they can't move, you know, the diagnosis, the working diagnosis is a joint bleed. You can use things like ultrasound, but, you know, they're not always going to pick up a joint bleed. And it can be often quite difficult. You know, there's patients who I have a normal ultrasound for, but clinically they look like they have a joint bleed, and I'll still treat them as a joint bleed. In terms of if people have ongoing pain or intermittent pain, it's more likely that they, rather than having recurrent joint bleeds, it may be that they have joint damage that resulted from an earlier bleed. And we'll often link them in with our orthopedic or physio team for an assessment, because it may be something that could benefit from surgery or an intervention.
Thank you. So I will move to the other one. Sometimes my daughter, for example, has all the symptoms of a joint bleed, but the ultrasound is not showing any bleed at all. After weeks of pain and discomfort, it will get better. Was a joint bleed, and was the ultrasound too soon to show the bleed? I hear more patients complaining about this, and more often than what we want is complaining about this, and more often than we want was a joint bleed after or looking at the damage.
What I'd say for the first thing is, I don't want everyone to think that if there's any problem with their joints and they have a bleeding disorder, it's a bleed. So it is important that we make sure there isn't anything else going on. So as much as I want people to recognize the fact that you can get a joint bleed, I also don't want them to put every problem down to a joint bleed and miss something else. So if you have somebody who has unusual symptoms, or if the picture, if it perhaps doesn't look quite as clear cut like a joint bleed, or there's some other symptoms, other things I'll look for are things like if people have joint laxity or hypermobility, because they can have sometimes some tendon damage or ligament damage that could be causing pain or swelling around a joint. So, you know, some people can have very hypermobile fingers or joints and can be more prone to things like that. So you can do an assessment of their other joints to see, could this be an issue? Or you could look at whether they need to have further imaging. An ultrasound is good at looking at blood and looking at some of the soft tissue, but it's not going to tell you if you have, say in your knee, a meniscal tear, or, you know, if you've damaged your cruciate ligament or things like that. So it's important that people are seen and assessed. And if it does look like a joint bleed, you know, they may need treatment for that. But if it could be some other symptom, they need further investigations and not just a put down to the bleeding disorder as well. What happens in our centre is that we have a physiotherapist that specialises in bleeding disorders. So he will come and see our patients, and we will also see them. So it'll be assessed by the physiotherapist and by our medical or nursing team. And then together we'll say, you know, I feel this is more like a joint bleed, or I feel this may be more a ligamentous injury, and we'll treat the patient appropriately. But everybody will be seen by the physiotherapist and followed up by both the physiotherapist and the medical team. So I think the multidisciplinary team, if you've got access to that in your centre, is really essential, because I rely a lot on my physio and they rely a lot on us as well.
Okay, thank you.
Question, at least in the chat. Oh no.
Yes, there is one comment. I had a problem with my big toe. They did an ultrasound and said they could see arthritis, but thought it was a ligament damage. They did an operation to repair the ligament, but after the operation, they say there was signs of a lot of bleeding into the joint. That bleed hasn't shown on an ultrasound.
Yeah, and often, you know, there's different stages that bleeds occur. So you can have a bleed that there's just blood in your joint. That's the first part of a bleed, obviously. But once you have blood shouldn't be in any joint ever. There's no normal reason for blood to be in a joint. So as soon as blood is in there, it sets off a big inflammation within that joint, and then it starts to break down the blood. So you'll often get kind of deposition, or you'll get you'll see like dots of kind of old or altered blood in a joint. Kind of the deposition of the iron that was in the blood could be visible in a joint if you've had bleeding into a joint before. And you can get inflammation in a joint, and that can be like a mixture between rheumatoid and osteoarthritis in the longer term. So it may be that whenever somebody had surgery, if they said it looked like there was bleeding in the joint, they could see old iron or old blood cells. It's hard to know, you know, without the particulars of the case, but sometimes you can see evidence of old damage. So once you have bleeding in your joint at all, you can set it up for damage in the longer term, because if some people, that can be a trigger of inflammation that can be ongoing in the joint. Some people, they can get one cycle of information and it settles down, and then they're fine thereafter. So it's very individual as well.
Thank you very much.
I might ask Baiba a question if that's okay. Baiba, what do you think we need to do as a, what does the medical community need to do to change things for von Willebrand? What would you see as just a small question?
The tiny one.
Look, it's even like a year or two ago, we were still talking about the fact that von Willebrand is so complex, please even like don't try to understand. And then we have doctors coming here and telling like how like bricks it brings all together, how your blood clots like in very easy way. So it doesn't make it complicated. And if you could, maybe you can start with editing medical literature, like the books in the schools. Because if it's just one paragraph about hemophilia and nothing about von Willebrand, I understand nobody has to know everything, and that type 3 is 1 in a million and type 2 is 1 in 107,000 people. So it's like very rare that a specialist would see a patient like that. But when we bleed, I think the most important is that you recognize and you help us understand if it's a bleed, and you treat it. Like you find out all the differences in the molecules and everything, what kind of treatment we need. But when we are in pain and when we are bleeding, you are there to help us. So to reach that, I think we have to speak even more than we do now. We have to have all these campaigns and patients coming and doing our part as well, filling in the registry data, sharing information, speaking openly to doctors. And yes, and just to realize that this might change like over years, because it's never the same. In my life, it was every year, it's like a new surprise, like, ta-da, it could be like this. And then I don't know where to find the answers. And if the doctors would be the persons that could have these answers, not just like once in a year when we go to a visit, but more often, I think, yeah, like we are all writing in our chat that we would be happy if we had doctor like you at home. But yes, so lead by example. Just tell everyone like to be compassionate and understand that we have these symptoms and we need help.
And,
Well, this is please.
I know, I was going to say, I also think it's very important that, we keep training more and more people and get more and more people specializing in it. And I'm, really excited to have people like Dearbhla working with us now, she's really a superstar in terms of what's up and coming for von Willebrand disease. So she's going to make things better for you now, Baiba, over the next decade or so. No pressure, Dearbhla.
I'm learning from the best, so.
I think this is a good place for Maria-Angela to remind that EuroBloodNet is a reference network in which all of us as patients and doctors can find advice from the other doctors. So it's not necessarily that we as patients travel the world to get the best medical care, but it's also can be our doctors who are calling up a doctor who knows a little bit more and just ask questions how to help us.
Indeed, thank you very much, Baiba, for mentioning that. Yes, so the ERN can arrange a second expert opinion or first expert opinion for complex case or for rare disease, and we can do it with several kind of method. We also have telemedicine platform that is settled on the 27 country of the European Union legislation, when you can insert all the medical records of a patient and ask for expertise, which looks great as I've explained it, but it could be very complicated. But we have also other solutions. So as we always say, please do not hesitate to contact the ERN for any information. We will guide you through all the possible resources we might have. Indeed. Okay, so maybe waiting if we have one final comment or question, we can advertise our next session of this comprehensive program. So it will be on the 6th of June, so more or less in 1 month, same time, 5:30 Brussels time. And we will talk about do not let people bleed their way to treatment, accurately diagnosing von Willebrand disease. And with us, there will be Professor Susan Shapiro from the Oxford University and Georgia Korosidou from the Greek Hemophilia Society.
And John Counter.
John Thornton, yes.
From EHC VWD Committee. We will have a trio again, but that time will be two patients and one
represented. Yes. Okay, so
just received thank you messages, and indeed I can confirm as the person who is present also on VWD chats that the chat of the committee is now exploding with the compliments to the clinicians that we have here today with us. Thank you very much on behalf of the EHC, both to speakers and to the ERN, and personal thanks to Mariangela for always being there.
It's mutual. I won't be here without all of you. Okay, so thank you very much again to the speaker for having shared their expertise with us, and see you on the 6th of June, and have a nice evening, all of you. Thank you.
Thank you. Bye.
Thank you. Bye.
Bye-bye.
Bye-bye.